Thank you so much, Heather. I'm delighted to be here this morning. And I'm also especially delighted to be honoring Dan Coffer's memory. This particular disease, Lewy body disease, in all of its various forms, was a passion of his, as I know you know. And as I was putting this talk together, I was struck anew by how frequently his name appeared, either on the list of authors or in the acknowledgements or in the citations and references of the papers that I'm going to be presenting this morning. So I'm going to start by sharing my screen. And then, okay. Hopefully you are now all seeing in front of you my full first slide, occupying as much of your screen space as you've allocated to this talk. And the title of it is Dementia with Lewy Bodies, Recent Advances and Research Opportunities. I am hoping to walk you through some of the newest understandings that we have about Lewy body disease. And then in the last 5 or 8 minutes to discuss some research opportunities and, more importantly, how you find out about them and how you would approach signing up if you were interested. In order to show you what is new and different, I will need to step back and give you a few basic principles that I suspect you're mostly familiar with. But please know that the entire field of Lewy body disease research is quite new. Although we've known about Parkinson's for over a century, the idea that there can be Parkinson's-like pathology in other parts of the brain and that constitutes almost a separate disease state is a relatively newer idea, and people are still ironing out the nuances. So in fact, some of the newest research happening right now, as we speak and published in the last few years, is still very basic conceptualization, categorization, and description of what constitutes the different forms of dementia with Lewy bodies. Okay, so the category of Lewy body dementias is now thought to comprise dementia with Lewy bodies, which is what we currently understand as being Lewy body disease. There is also a fairly similar but slightly different construct called Parkinson's disease with dementia, in which somebody presents first with Parkinson's symptoms that typically, as with most cases of Parkinson's, responds to a medicine that increases the amount of dopamine in the brain. And over a period of time, that individual with Parkinson's disease develops dementia. Typically happens 5 or more years after their first symptoms. And that person is considered, even if they have many of the same features as someone who has dementia with Lewy bodies, still to have kind of a somewhat different disease state. Please know that this is in hot debate, and you may hear some doctors telling you that you have, if you have dementia with Lewy bodies, that you have a form of Parkinson's or that you have a Parkinsonism, okay? And they are not wrong. It has to do with the way this field is evolving and how people have chosen to name these things. In addition, there's a third clinical syndrome, okay, that is now coming to be understood as a precursor or prodromal state of dementia with Lewy bodies, in which not all of the symptoms, not all of the features are necessarily present yet, but we have a suspicion that that person is on their way to developing full-blown dementia with Lewy bodies. And so that has gotten its own category in this scheme of the different Lewy body dementias. And if you'll notice, I have not yet, other than in passing, used the term Lewy body disease. And that is because currently the way we're thinking about disease states, the terms I had previously used for clinical syndromes are what we see in the office, what you see in the day-to-day, in living people. Whereas Lewy body disease is defined pathologically. It's based on what you see under the microscope, and we blame the symptoms of the Lewy body changes on a series of abnormal protein accumulations in the brain that ultimately turn into what we call Lewy bodies, named after a Dr. and Professor Lewy, who was the first one to identify them. And these Lewy bodies are comprised of a protein called alpha-synuclein. And if you look at that schema on your screen, you'll see that the idea is that there is a single normal alpha-synuclein protein, which is part of the intracellular components of neurons, and it starts to misfold for some reason. And when a protein misfolds, it gets very sticky, and it tends to glue just like Velcro, primarily to itself. And as those little, what they call oligomers, tiny filaments, glue themselves together more and more, they become fibrils, which become tangles of fibrils, which eventually become the Lewy body. That is what was seen over a century ago inside of individual neurons, brain cells, as big round blobs of material that at the time we didn't know what they were. And is how this disease, this set of diseases, right, got its name. Okay. We know that Lewy body dementias have gone through some evolution in terms of what is the core, what are the hallmarks, what are the key features that define this disease and distinguish it from other related neurodegenerative disorders such as Alzheimer's, Parkinson's, Huntington's. There are a number of others. So the answer at this time, since 2017 and the fourth consensus report of a large think tank called the Lewy Body Disease Consortium, is that to have Lewy body dementia, first and foremost, you have to have dementia. And in addition to that, you need two or more of the following four things. One is Parkinsonism, which is this physical motor set of signs that are what we think of as the hallmark of Parkinson's disease as well. Visual hallucinations, which you will hear quite a bit about a little later in this day. An unusual feature of a neurodegenerative disorder, cognitive fluctuations, which tend to be more obvious a little later in the disease and not right at the beginning, and manifest as periods during the day or different days in which somebody is much clearer and sharper and more alert, more with it, more like their old selves than at other times. Finally, the fourth core feature is REM sleep behavior disorder, another thing you'll be hearing a lot more about later today. So I will say only that it's a tendency to act out your dreams while you're dreaming and not lie still. Okay, just in case you aren't familiar, I wanted to point out that dementia is a decline. It's defined as a decline from your baseline in cognitive ability, and that decline is bad enough that it impairs your routine daily activities, and we can't attribute that decline to a medical or a psychiatric illness. Also want to point out that dementia requires more than a single deficit. So in other words, if all you have wrong with you is memory loss, we would call that amnesia. We wouldn't call it dementia, okay? And so that also implies that other aspects of cognitive function can be impaired, and often are, in Lewy body disease. And in fact, memory per se can be quite normal or relatively normal in a person who has a full-blown dementia. Okay, oops. Lewy body disease is one of the most complex and broad, wide-ranging diseases that we know of under the neurodegenerative disorders umbrella. It seemingly impacts, or can impact, not that it always does, virtually everything the brain does. Okay, so on this list, you'll see everything from a severe sensitivity in some individuals to medications that impact the brain, such that teeny tiny doses exert a very overwhelming effect. You can see problems with ability to stay upright, ability to maintain a normal posture, occasionally even in the sitting position, and other physical functions. You will hear about autonomic dysfunction that can include a whole array of symptoms that are governed by the brainstem. You can also see very psychiatric kinds of symptoms as are listed here on the other side of the slide. Why is that? So the answer, and I'm going to do this in a quick, complicated, and a second simpler step, is that the alpha-synuclein tangles that turn into Lewy bodies and damage, harm the neurons, often starts down in a part of the brain known as the brainstem. That's down here, affecting a lot of specific brain structures that are related to things like blood pressure, sleep, mood, as well as impacting your basic organs, bladder, sex organs, heart, and intestines. And those Lewy bodies and the protein abnormality that it creates them will pass from cell to cell, and they will actually ascend through tracts in the brain from the brainstem all the way up into the brain tissue and the cortex itself. And sometimes it actually starts up in the cortex and moves down. I want you to think of all of those different parts and pieces of the brain as the different parts and pieces of an elephant. If you're familiar with the parable of the elephant and the three wise men, the wise men were blind, and they were asked in presumably an Asian country long ago to give their opinion as to what an elephant was. Each went into where the elephant was standing, right, and happened to touch a different part of it. You know, one touched the trunk, one touched the side, one touched the tail. And so each gave a very different description of what that animal was really like. And in fact, Lewy body disease, depending on who you have met and talked to and what their individual symptoms were, can sound like a whole lot of different diseases. One in which you see a lot of constipation, bladder and sexual dysfunction, as well as taste and smell changes, versus another person who has a whole lot of problems with their thinking and psychology, and somebody else who looks like they have pretty much Parkinson's disease with just a little bit of thinking trouble. I'm going to move on from what we have known about Lewy body disease from the last several decades to somewhat more recent information, okay? And the first of these more recent findings is a growing awareness and understanding of how often these neuropathologies, the neurodegenerative disorders, exist not just one by one, but in combination. And because the number one most common frequent neurodegenerative disorder is Alzheimer's disease, and the number two is Lewy body disease, guess what? They will happen in combination relatively often. So when we have looked in autopsy studies carefully, we have found that of those people diagnosed in life as having Alzheimer's disease, somewhere between a third and a half of them will have at least some Lewy body pathology in the brain. And the reverse is true. Up to 50% of people with Lewy body disease in life will have at least some Alzheimer's disease pathology. And of course, as you might predict, people who have mixed disease, who have both pathologies, will tend to have more severe symptoms and shorter survival. Okay. What I'm going to stress in this slide and the next is that both of these pathologies, alpha-synuclein causing Lewy bodies and amyloid and tau causing tangles and plaques in the brain, these both exist on a continuum, okay? And especially with Lewy body disease, the continuum has actually been formally incorporated into the description. So when you have brainstem only Lewy body disease, that is a brainstem form of Lewy body pathology, and we don't call that diffuse Lewy body disease. There's also an intermediate or a transitional form in which the alpha-synuclein protein is in the brainstem and in the limbic system. So the limbic system is the part of the brain below the cortex that governs emotions and memory. And there is also a form that is what we call diffuse Lewy body disease, that impacts the cortex, that outer covering of the brain as well. And these are the people with the most severe Lewy body symptoms. And then along the way, you can also have low, medium, or high levels of Alzheimer's pathology. So in the last few years, people have really tried to better understand what the separate contributions are of these two conditions or these two types of disease states in one single person. And so you can see on this slide a graph, and they have compartmentalized Lewy body disease and Alzheimer's pathology into a 4-category matrix. So they've got transitional T, Lewy body disease, compared to D, diffuse Lewy body disease. Okay, and then this L versus H refers to low amounts of tau or high amounts of tau, which is an Alzheimer's pathology. And what they concluded were a few things. They looked at several hundred people whose brains they categorized in this way. And they found that the diagnosis of Lewy body disease was highly likely when the distribution of alpha-synuclein pathology was greater than that of tau. They also found that diffuse Lewy body disease, the kind that has the spread up into the cortex, okay, these people had more severe pathology of each type and a shorter duration of illness, meaning shorter survival than those who had only the transitional form in the brainstem. And Interestingly, these three pathologies together, the amount of amyloid protein, tau protein, and alpha-synuclein, accounted for 1/4 of the total variance in the duration of illness. So they had a big impact on how long survival was. Now, this graph here to the side is not survival. What it's showing you is the dementia rating scale. And so level of 124 or so, where people start out, is considered mild dementia. And so all of the people in this study at the time of enrollment averaged around a mild level. And then over a period of 6 years, you can see how much their dementia progressed. A level of 50 would be considered moderately severe. Obviously, these are all people who are still alive after 6 years. And you can kind of see the distribution going from the folks who had both low tau and low amounts of alpha-synuclein doing the best over the long term, and then the trajectory of the high tau, high synuclein group in that purple line down at the bottom. Oh, for reference, I should add, they had a comparison group of people who had pure Alzheimer's disease. So if you want to think of how quickly an Alzheimer's patient progresses as kind of your norm, if you will, you can see that the people with transitional Lewy body disease and low levels of Alzheimer's pathology progressed at slower rates than that of your typical Alzheimer's patient, whereas the other groups tended to go a little bit more quickly. The next area of research that I'd like to highlight is the enormous progress that has been made in the area of what are known as diagnostic biomarkers. I will say that 10 years ago, we had virtually nothing that would tell us with certainty whether somebody was developing Lewy body disease or not. The best we could do was a so-called clinical diagnosis in life. And based on that checklist I showed you earlier, you know, we would tick off the number of cardinal symptoms and the number of supportive symptoms, and we would say that that person either had clinically probable or clinically possible disease. Okay. We have moved forward from that, and with the advent of these biomarkers, we have a greater degree of precision, more ability to be confident in our diagnosis. On this first page, I'm showing you 2 types of biomarkers that look at phenomena that are kind of secondary, if you will, to the Lewy body process or Lewy body pathology, but they are very closely tied and thought to be good markers. The first is that REM sleep behavior disorder that Dr. Roth will talk to you about a little later in the day. The way to definitively diagnose REM sleep behavior disorder is with a test called a sleep study or polysomnogram. And you can see this model wearing the various gadgets, electrodes, and apparatus that are part of a typical polysomnogram, in which you come to a lab and you sleep through the night, and we monitor what you do, your brain waves, your body, your breathing, and we can tell if you remain appropriately paralyzed, meaning unmoving, during the dream part of sleep, or if your muscles tend to be more twitchy or active. Similarly, people with alpha-synuclein abnormalities, that alpha-synuclein not only affects the brainstem and the brain the way I've already showed you, but also affects nerves in the rest of the body and the periphery. An important area that alpha-synuclein can target is the heart. because the heart receives signals from what's called the autonomic nervous system. And in Lewy body patients, the autonomic nervous system is abnormal. Therefore, the heart's what they call sympathetic nervous system component is also abnormal. There is a type of nuclear scan called an MIBG. You don't want to know what that stands for. It's like way too many syllables. This type of nuclear scan can actually see directly how much sympathetic innervation there is to the heart. And as you can see on this picture, in a person with more extreme Lewy body symptoms, there's virtually no signal whatsoever. Above, you can see a little bit of pickup from the lungs. Below, this is the liver, where this particular dye actually ends up, which is why it's so bright. But right here in the middle, in that empty space where the heart should be and is on the normal scan, right, you can see what it should look like. So these are non-specific biomarkers. We're starting to get more specific ones. Okay, so a little less than a decade ago, 7 or 8 years ago, the FDA approved a form of brain scan for a machine called a SPECT that looks directly at the brain's amount of dopamine function. So in people with both Parkinson's and Lewy body disease, the amount of dopamine that is made in the brain is significantly decreased. This type of scan looks at what's called a dopamine transporter. It's a protein that allows the dopamine to go where it needs to go. And that is a part of the brain known as the basal ganglia. The basal ganglia live deep inside your brain, and it's a pair of structures shaped kind of like what you see here on the normal side. And when Lewy bodies damage the neurons, they get rid of the neurons that make dopamine. And so you can see that the amount of dopamine transporter uptake is significantly lower. This type of brain scan exposes you, like the cardiac one, to a small dose of radiation, but really not more than a CAT scan of, say, the chest or abdomen. And it gives you more specific information. So all forms of alpha-synuclein disease will create some degree of change on a DAT scan. Similarly, and this is brand new, just approved in the last 15, 18 months, is a way of looking at alpha-synuclein in the nerves of the skin. Believe it or not, they even get there. And they get there rather early, much earlier than you would think, because it turns out that you can diagnose sometimes people who have what's known as prodromal Lewy body disease already by the use of this type of skin nerve fiber biopsy. This test is now available from CND Life Sciences. They've termed it the SYN1 test, and it is able to visualize abnormal alpha-synuclein in these nerve fibers via a type of immunofluorescence imaging. And it's important to know that this is quite specific to synucleinopathies. Okay, so synucleinopathies being not just Parkinson's disease and Lewy body disease, but another third condition that we haven't talked about this morning called multiple systems atrophy. It is much rarer in general than either PD or DLB. This is a simple skin punch biopsy procedure done in the office with a little local anesthetic. And the punches are the size of the head of an eraser, you know, on a typical number 2 pencil. The 3 sites where we do it, you know, are in the leg, the thigh, and the back of the neck. There are now coming to be better understandings of what constitutes the precursor to full-blown dementia with Lewy bodies. And one of the things that we have learned is that not everyone who develops DLB develops it from the starting point that we're used to, which is that of a mild cognitive impairment onset, right? It stands to reason that before you develop full-blown dementia, you'll go through a period where you have some slight slowing of thinking or some trouble with the hallmark Lewy body processes of visual spatial relationships or attentional and multitasking ability. It turns out, are 2 other ways in which people will develop full-blown eventual Lewy body disease. These are less well characterized, less well understood because they're much less common. But there's both a psychiatric onset and a delirium onset. So in psychiatric onset, people will get a late in life first ever episode of major depressive disorder, or they'll develop a late in life onset of psychosis. They can also sometimes have developed very, very severe, what are called psychotic levels of anxiety, in which the degree of anxiety is completely divorced from what's actually happening in your day-to-day activities, or the rapid onset of such severe apathy that it is termed catatonia. So the third way is even less common, and that is with the onset of a severe confusional state known as delirium. We usually see delirium happening in the setting of an acute severe illness, but in people who later develop Lewy body disease, that delirium is not provoked usually by any particular underlying process. In both of these types of onset, as with the MCI onset, not long after the development of these problems, you start to see the remaining components that qualify you for the diagnosis. And so what do you do with individuals who show up in your office with just a delirium that just hasn't resolved, or a delirium that has recurred now for the second time? You have some suspicion. So this slide is trying to synthesize some of the information I've presented to you from the biomarkers. It's also adding some information that I have not presented to you regarding Alzheimer's pathology biomarkers. And what it's saying here in the aggregate is that you starting with simple bedside assessments, looking for characteristics that are more typically Lewy body-like at the bedside, like diminished visual spatial attention and attentional ability as compared to severe impairments in memory or naming. And then moving down toward some of these new associated biomarker tests, including ones that I have not described for lack of time. And unfortunately, also with the passage of time, you will almost always now be able to sort out whether this was a one-time problem that goes away, or whether this is a person who has pure Lewy body process or a pure Alzheimer's process, or, as we are understanding, often happens, a component of both. So in the last little bit of my time, I'm going to talk about the current landscape with regard to research studies, okay? Lewy body disease, since it's so much newer than either Parkinson's or Alzheimer's, has had so much less in the way of clinical looking for treatments. It was a problem for a long time, even to define the patient population. How can you do research on something that you don't know how to identify in the community? So now that we are good at that, we've started looking at some of the features we already know the most about because they happen in other diseases, things like Parkinsonism and REM sleep behavior disorder. How do we try to manage those? There have been completed up until now 14 different types of interventions that have been tested in this population, targeting all of these different symptoms or targeting disease modification directly, meaning slowing down the disease. And I'm highlighting here number 9, a drug called neflamapimod, which is the first drug out of the gate to actually have a significant impact, at least on the phase 2 study, on Lewy body disease pathology itself. You may have heard about it in the news. Their top-line results were announced in late 2020. They had a second announcement of these results last winter. This was a short 16-week treatment trial of a p38A kinase inhibitor. I have in the box what it's supposed to do. And the results were relatively impressive. They had both a twice-a-day treatment group and a 3 times a day treatment group. And if you look here at the figure, the gray bars are the placebo arm, and the orange bars are the treatment group. And the y-axis here is how much worsening people had on this scale called the sum of the CDR, or clinical dementia rating scale, over a period of 16 weeks. Now, it looks like a lot of worsening. It really isn't that huge of an amount. There's just a lot of space between these numbers. But the point is that the gray bars had much more significant worsening than the orange ones. In fact, at 8 weeks, it looks like the Lewy body disease high 3 times a day treatment group actually did slightly better than they started out. Of course, unfortunately, by 16 weeks, both groups were worse. But compared to placebo, a 2/3 reduction in worsening over the 16 weeks of this study. This company has had some financial struggles since then, and they're just thinking about getting their next study underway soon, but not yet. So how do you find the next horse to bet on? How do you find a research study that's actively going on now that you can join? So I encourage everyone who has an interest in doing this to go to a website called clinicaltrials.gov, okay, and type in the term Lewy body disease, choose your country of the United States, and select at the top this little circle, recruiting and not yet recruiting, rather than all studies. Once you've done that, you will discover a list that looks like an unedited version of this. And I realize that this is crazy long. There's a few things I'm going to highlight on this. First of all, there are a total of 22 studies. 22. 22 seems like a pathetically small number, and yet it's the most that we have ever had. I'm going to highlight here, out of that 22, there are 8 that are drug intervention, or sorry, that are intervention trials intended for patients. One of them, they're not all drugs. One of them is a stem cell transplant experiment. And another one of these is a device experiment using something called transcranial direct current stimulation. But all of these are direct intervention studies with patients. There are 3 that are caregiver interventions because this disease is really stressful on caregivers. And there are also 3, because we don't yet have that perfect diagnostic test, there are also 3 that are diagnostic studies testing, including the synuclein 1, which still doesn't have a large sample that proves that the test is effective at distinguishing multiple different synucleinopathies from each other. So there are also diagnostic studies. And going to point out that there's room for 480 people amongst these 8 studies that are happening throughout the United States. The sponsors are listed here, and you can look here at the expected completion date to get a sense of which ones are about to wind up and which ones, most of them, are likely to accept new enrollments for quite some time to come. Also note that there's a lot more room for caregivers if you want to be involved in something that might help you. I'm going to highlight 2 of these as my last couple of slides. So an example of a caregiver study is this We Care Advisor research study done by an old friend and colleague who's now at UC Davis, Dr. Helen Kales, and they are piloting the use of an online tool that will work with you to give you tailored, personalized information about strategies to help manage dementia-related behaviors, to reduce your stress and enhance your confidence in caring for your loved one. And we here at UNC will be starting a new treatment trial with a drug. The drug is called CT1812. It's a sigma-2 receptor modulator. Again, rather than describing the biology at length, you're welcome to look at what's written here. But the idea is that this drug may actually benefit most those people who have both Lewy body and Alzheimer's pathology together, because they're hypothesizing that their drug will work on both abnormal proteins. And so we are planning to enroll 120 participants, the study nationwide across 30 sites, 120 participants. And for each individual, it's a 6-month treatment commitment, 9 months total. You have to be willing to have and able to have both lumbar puncture and MRI. And you need to be relatively mild. So this mini mental state score needs to be no lower than 18. If you're interested and you're eligible, here's an email, or just reach out to me or one of the DANC members, and we can get you in touch with the study coordinator. Finally, the last slide, the best way to hear about other studies and to learn more about clinical research opportunities for brain health across all of the types of dementia and disease states is by joining the North Carolina Registry for Brain Health. I highly encourage everyone listening to sign up by going to that website's URL that you see. It's just a minute of your time, and we will keep you posted about what's going on in the Triangle, around North Carolina, and more generally. I am happy to, if there's any time left, Heather and Lisa, to answer any questions that have come through.
So we have had several questions, Dr. Bozoki, but I think in our last 3 minutes, there's two that seem to be coming in more than others. And one is, where can I get tested with the dermal nerve fiber biopsy? Who orders that? And if my physician does not know about that, how can they learn about that?
So any physician can order the test, as far as I know. And the test is only warranted if there is some concern for the possibility of Lewy body disease or synucleinopathy, and yet, it hasn't been confirmed by the totality of your symptoms. It is, your physician can learn more about it by going to the CND Life Sciences website, or if they wish, they're more than welcome, your physician, to reach out to me, Andrea Bozoki, at UNC, and I'm happy to share information with them and point them in the right direction. The biopsy itself, we do on site. We've trained several of our nurse practitioners, but in general, dermatologists and skin surgeons are all over the place, able to do them. And sure, lots of people with a minimum of training are able to perform the biopsy, and it's not a big deal.
Thank you so much.
What was the other question, Lisa?
The other question is about heredity and genetic connections and the latest research, especially for DLB, PD, and MSA.
That's a big area, not something I can answer easily. It's certainly not comprehensively in a minute, but I will say this, that intriguingly, there is a gene for glucocerebrosidase, or GCA, which, when it's very abnormal, is the cause of an infantile process called Gaucher's disease that's terrible and deadly in little babies. But it turns out that gene, certain types of abnormalities are strongly associated with specifically diffuse Lewy body disease development. It's found in about 7% or so of individuals, sporadic individuals with Lewy body disease. It is autosomal recessive. And so you would have to have 2 copies of it to have a real problem. There's some exploration of that. In general, there aren't a lot of genetic associations. This is one of the first that has been found for familial Lewy body disease.
Very interesting. Well, we'll have next conference, we'll have to do a whole session on that one, but thank you so much for everything. We will share your information with our attendees so they can reach out with questions, and we really appreciate your time, you being with us today. Thank you.
Thank you.